I'm Charles Bankhead of MedPage Today. I'm at the Society of Gynecologic Oncologists meeting in Tampa, where SGO President Dr. Andrew Berchuck of Duke University sat down with me to discuss the organization's current issues and goals. Raising the visibility and recognition of the specialty of gynecologic oncology tops the list of priorities for his term as president. Could you tell me a little bit about what some of the issues of concern to your membership are and how you hope the organization and your specialty can go about addressing those?
Sure. Gynecologic oncologists are subspecialists who care for women with cancers that are unique to women. So this is primarily ovarian, endometrial, and cervical cancer, but also rare cancers such as vaginal vulvar cancer or gestational trophoblastic disease. We provide both surgical care and chemotherapy and sort of A to Z treatment and follow-up. We follow patients from diagnosis through treatment, and if treatment fails, we also provide palliative care and help patients and their families deal with difficult end-of-life issues. I think one of the biggest obstacles that we face is that many physicians and patients are unaware of the special expertise and training that gynecologic oncologists have in managing reproductive cancers. So, for example, endometrial cancer is the most common malignancy that we treat, and there are about 40,000 new cases annually in the United States each year. Fortunately, most uterine cancers are confined to the endometrium at diagnosis and can be cured with hysterectomy, but about 20 or 30% actually are metastatic at the time of presentation, and the main way in which that determination is made is by performing surgical staging, which involves dissection of the regional lymph nodes in the pelvis and aortic area. And gynecologic oncologists are, again, specifically trained to perform a surgical staging procedure that can give us the best assessment of a patient's extent of disease at diagnosis. So if indeed the cancer is just confined to the uterus, then surgery may be all that's needed. But for those patients who are found to have early metastatic disease in lymph nodes, other adjuvant types of therapies such as radiation or chemotherapy would be employed. But unfortunately, many women with endometrial cancer never make it to a gynecologic oncologist and so don't have surgical staging. Again, those who have surgical staging and are found to have metastatic disease would also qualify for clinical trials. The Gynecologic Oncology Group is our cooperative trials group. It's a national NCI-funded group, and there are a number of ongoing studies that are looking at the appropriate role for novel types of treatments like new chemotherapy drugs, biological agents, and so forth. Likewise, ovarian cancer is the second most common malignancy that we treat, and again, most patients with an ovarian cancer present with a pelvic mass and are often operated on by general obstetrician gynecologists or general surgeons. When a pelvic mass is indeed found to be ovarian cancer, it's again important that the proper surgical management be performed to start things off on the right foot. So if it looks like a cancer that's early and just confined to the ovary, again, some patients have early metastatic disease that can only be found through surgical staging by sampling lymph nodes, omentum, peritoneal biopsies. Conversely, many patients have advanced metastatic disease at presentation, and it's been well proven that patients who undergo so-called optimal debulking and have most of the metastatic disease removed have the best chance of prolonged survival. So often those debulking procedures require bowel resections, diaphragm stripping, other fairly radical procedures to get the patient to an optimal status. In the last few years, we've come to believe that intraperitoneal chemotherapy may provide the best chance of long-term survival for patients who are optimally debulked. So again, gynecologic oncologist has the best chance of optimally debulking a patient with ovarian cancer. Gynecologic oncologists are also very experienced with intraperitoneal chemotherapy, which is a bit more complex and labor intensive. So again, I think, in summary, our main challenge as a subspecialty and individually as gynecologic oncologists is to increase awareness among the public and other medical professionals of the special training and expertise that we bring to the management, particularly of endometrial and ovarian cancer, but also all gynecologic cancers. And we feel that in order to assure the best outcomes for patients with these diseases, that women should have access to the quality care that we can provide.
Thank you, Dr. Berchuck. From MedPage Today, I'm Charles Bankhead.